this treatment affect the skin?
Will neoadjuvant chemotherapy affect the skin? No, there's no. Obviously, radiotherapy treatment affects the skin. As I've explained, it can cause reddening of the skin, but that's temporary. Sometimes in the long term, you can get little blood vessels on the skin that we call telangiectasia, but that's after radiotherapy. After chemotherapy, there isn't a problem with the skin, usually, no.
So what are the other potential side effects of neoadjuvant treatment?
Well, the side effects of neoadjuvant chemotherapy are very similar to the side effects of any chemotherapy treatment. Chemotherapy is an unpleasant treatment for patients. It causes a lot of tiredness. It can cause sickness. It can cause loss of the hair, which patients are often very distressed about, although almost always hair comes back afterwards. It can also affect the blood counts. So patients are not able to fight infections so well while they're having chemotherapy treatment. So anyone that has chemotherapy will know that they have to report to their doctors quickly if there's anything that suggests an infection. So the side effects of chemotherapy are just the same whether you give the treatment before or after the surgery. And chemotherapy is a difficult treatment and it is unpleasant. It's never as bad as it's often imagined to be. I see ladies with breast cancer and they burst into tears when I talk about chemotherapy treatment because lots of bad stories circulate. Everybody knows a bad story about chemotherapy, but it's almost always not as bad as often it's imagined to be. And most patients, although it can be difficult and there are side effects, most patients can manage chemotherapy treatment well if they have good support. It's very important to be positive. It's much easier to accept treatment if you're positive. It's hard to be positive, when you have a diagnosis of breast cancer, and everybody fears this disease, of course, and it's such a common disease that everybody knows somebody who's had treatment for breast cancer or died from breast cancer because it's so common. In the UK, it's common in India, it's common in many, many countries. So everybody knows that it's a very difficult disease, but it is increasingly curable. More and more ladies with breast cancer are cured. In fact, the majority. In the UK, most ladies who I see with early breast cancer will be cured. Not everybody, and there's no guarantee, but most ladies will be cured. So it's important to emphasize those positive aspects, but it's still a very, very, a feared diagnosis, a dread diagnosis, and the treatment is difficult. Surgery is difficult. Chemotherapy is difficult. Radiotherapy is not an easy treatment. But all of these treatments combined improve the chances of cure. And we are curing more and more patients with breast cancer. So it's important to emphasize that to patients, that there is a realistic prospect of cure for most patients that we see.
Nowadays, can we reduce the metastasis by the radiotherapy?
This is a complicated area. Drug treatments like chemotherapy, like anti-hormone treatment, drugs like tamoxifen, and sometimes other drugs like Herceptin treatment are used because they can kill single cells that may have left the cancer before the surgery or even before the patient comes to see the doctor. So we give those drugs because we are treating all of the patient in the entirety. So we use those drugs. So those drugs are very good at reducing the risk of metastasis. And it's metastasis that mostly causes death. But radiotherapy treatment is mostly to stop a recurrence of the cancer in the place where the cancer started, in the breast or in the mastectomy area. And radiotherapy is mostly directed at that problem, and it's very, very effective. But it has been shown that because radiotherapy reduces the risk of local recurrence of the cancer coming back where it started, that in itself can also improve the chances of patients surviving and of those patients not developing metastases, as you've asked. So it's a complicated explanation. Most of the work at stopping metastases, stopping secondary breast cancer, is done by the drugs. But some of it is also done by the radiotherapy and, of course, by the surgical treatment as well.
Will radiotherapy or any other treatment affect the fertility in any way?
Radiotherapy is not, of course, given to anything other than the breast. So for a young lady who has early breast cancer, perhaps a lady who, let's say, is 30, who hasn't had children, radiotherapy directly should not affect fertility. But sometimes drug treatments can. So it is important, but this is a very complex area. And so it's very important that if we have a young lady, that if I see a young lady in her late 20s or 30s who wants to consider a family, who wants to retain her fertility, that we have a careful discussion with her about the pros and the cons of trying to do that, because it's a difficult problem. In men, preserving fertility is easy. In women, it's much more difficult. And even in Western countries, in the UK and the US, it's a difficult process with uncertainty as to how successful it would be. So yes, drug treatments can affect fertility. Chemotherapy can sometimes stop the ovaries working. Sometimes just temporarily, just for a short period, but sometimes permanently. And obviously, if a lady's ovaries stop working, then she will lose any fertility. For younger ladies, often her ovaries will stop working, but they will come back to work afterwards. So there's the chemotherapy, but there's also the hormone treatment, because if we use hormone treatment like tamoxifen, ladies should not try to get pregnant on tamoxifen. So if I have a young woman who's 30 and I start her on tamoxifen, I would say to her, you have to be very careful not to get pregnant. And it is very difficult to get pregnant on tamoxifen, but it shouldn't happen. So ladies should not be thinking about pregnancy while they're on tamoxifen. And you see, we give tamoxifen often for a long period of time, for 5 years, or even longer. So that can be a big problem. So preserving fertility is a complicated problem, and it can be very difficult. And although we will always try to help a patient if she wants to do that, we will have a discussion about the possibilities that there are. And sometimes it's possible to help her, but sometimes it's not. And those ladies will lose their fertility because we want to get on with the treatment for the breast cancer. You know, we want to try and do what we can to stop the breast cancer, to get rid of the breast cancer, to try and cure that patient. That's the most important thing. Fertility is important, but not quite as important as saving that young woman's life. So it's a complicated area, a difficult problem.
Do you find breast cancer in men?
Yes, sometimes you do. And it's often thought that breast cancer only occurs in women. But of all the cases of breast cancer, probably about 1% occur in men. So it is a rare disease in men, but it does occur. And we treat it in a very similar way. Surgical treatment, radiotherapy treatment sometimes, chemotherapy treatment sometimes, and anti-hormone treatment sometimes. But men are very much in the minority. Particularly in younger men, one has to think of the possibility of a genetic cause for breast cancer. But still, most of the time, there isn't a genetic cause. So it is a rare disease, but it does occur. So what will happen is my waiting room will be full of ladies, all sitting in one end, and there'll be one man on his own at the other side of the waiting room. But the treatment is very similar, yes.
Coming to EBC-TCG, what exactly is EBC-TCG?
Well, the Early Breast Cancer Trialist Collaborative Group is a worldwide collaboration of scientists and clinical researchers who come together, who agree to share all the information that they collect from clinical trials. So in early breast cancer, all of the clinical trials that happen in early breast cancer, we try to bring together in the EBC-TCG. It's not always easy to say that, but I think I got it right, as you did as well. It's based in Oxford, in England, and every 5 years we have a meeting in Oxford, and I'm lucky enough to go to that meeting, and we look at all the information, all the data. But it's a lot of work, it's a huge effort, and it's important to understand that it's not just the UK and Oxford that does this. All of the trialists all over the world, some from India, from other parts, from Asia, from Far East, from Australasia, from America as well as Europe, all the big groups and all the big hospitals usually agree to share their data, to bring things together. And so we can, from that process, derive conclusions that are very robust. And we can be much more definitive, much more positive about the treatments that we give. So if we do a small trial, we might see a small effect of treatment. We won't be sure whether it's real or whether it's a statistical fluke. But if we do a big trial, it's better. If we do a meta-analysis, which is a much bigger trial in a sense, we can be much, much more confident about the treatments that we're delivering in routine practice. So it's a very powerful way, a very effective way of bringing all the information together. So all the trialists around the world, and then all the doctors around the world who treat patients with breast cancer can understand the benefits of these treatments much more comprehensively. And this information is often, most of it is freely available. Anyone that can get on the internet can look at the analyses, can understand the process, can look at sometimes some of the publications and the results and the reports that come out of the Oxford Early Breast Cancer Trialist Collaborative Group process. So it's a very open process. It's not secret. You could have a look on the website if you wanted to and try and understand how effective chemotherapy is, or radiotherapy, or Herceptin treatment, how long we should give hormone treatments for, whether bisphosphonate treatments are helpful, and if so, how helpful are they? It's a very powerful exercise, and I am a firm believer that we should continue to support this process.
And what is the present status of EBC-TCG?
Well, it's alive and thriving, and lots of work is going on. There is a publication we hope soon to come out about radiotherapy treatment. So we're at the moment focusing on radiotherapy. There's also a lot of focus on bisphosphonate treatments. I gave a presentation today about bisphosphonates in early breast cancer. Very interesting results, very exciting. Results that could change practice and make us consider differently the treatments that we have. So the Oxford overview process, the early breast cancer trialist collaborative group process is very much alive and thriving. And we're also not just looking at the benefits of treatments, but we can look at the side effects. You asked me earlier about the side effects of radiotherapy. Well, we have all of the trials, all of the randomized trials of radiotherapy. Randomized patients who have radiotherapy, those that didn't have radiotherapy. We can follow everybody up for 20 or 30 years, and we can understand better the side effects of treatments. And we can then change our practice. So we now know that we have to be careful about giving the heart radiotherapy treatment. And we know that because of all the trials that have happened, but particularly the work that's been done by the Oxford overview process, contributed to by trialists all over the world.
So it is beneficial for the public and the research bodies, but how is it beneficial for the government?
I think that a good government would want to know how effective the treatments that are being given by the doctors in that country are. They would want to understand that. And I think that governments have a difficult job because we do not have endless money. There's not a limitless pot of money to treat patients with breast cancer or with anything else. So I think that the power of the overview would be to supply robust information to the funders of healthcare and those who are responsible for the governance of healthcare, so that they can understand how beneficial the treatments that they're using, that the doctors in that country are using, and also how costly, so they can make a judgment about what's the benefit, what are the side effects, and what's the cost. Because although we may not like it, in the UK, even in the US, in India, and lots of other countries, we are struggling to be able to pay for healthcare, and difficult choices have to be made. But it's better to make those choices with good evidence. So I think a good government would want the population of women with early breast cancer to be able to access treatments that we are certain are effective. But governments also have the information so that they can make judgments about how effective treatments are in relation to the cost of those treatments. And they could consider maybe a treatment that's just as effective but less expensive. Make those kind of difficult choices that doctors don't like to make.
Thank you, sir. Thank you for spending your valuable time with us. It was a great time with you.
Well, I enjoyed it very much. Thank you very much.
Thank you.